Thanks for joining us for this Part B Oral Surgery Common Rejections and Denials webinar. This webinar is designed for those who submit claims to Medicare on the CMS 1500 claim form or the 837P electronic claim. My name is Mary Mucko. I am a specialist on the Provider Outreach and Education team at WPS Health Solutions. I will be your speaker today, and assisting me is my friend and colleague, Aline Sigler. We include this disclaimer in all our education, and we really do so just simply to remind learners that although we made every effort to provide current information that is correct, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. And finally, CMS prohibits recording of this presentation for profit-making purposes. We are recording this webinar and we will post it as an encore presentation and on our YouTube channel. Stay informed about new postings of the latest WPS Encore presentations and other education by reading the Education e-news that we post each week on Wednesday. Here is the agenda for today's presentation. You will note, if you looked at the advertisement for today's webinar, that this webinar really focuses on data. We're really not talking about policy or coverage criteria today during this webinar, because this webinar focuses on data. The data is for the common rejections and denials for specialty type 19 or oral surgery Medicare providers. Just as we stated in that advertisement, I will define rejections and denials, and I'm going to review the data for common rejections and denials. So I will be revealing to you the most common reasons for rejections and denials. I'm going to talk about how you can fix those claims or avoid them altogether, those rejections and denials, that is. And I will be providing you with just very many resources, many of which are actually hyperlinked in the electronic presentation that you have available for download. Before we get started, though, I do want to talk a little bit about the CPT copyright notice. This is the copyright notice that we provide for the American Medical Association. Your continued participation in this webinar infers that you agree to the terms of the copyright notice. Should you not agree to acknowledge this copyright notice, you may disconnect now from this webinar. So to fully understand rejections and denials, it's important for you to recognize the path that a claim takes or the life of the claim. As I mentioned to you earlier, I'll be talking about rejections and denials today during this webinar, but I do want to remind you that by filling out and completing the brief survey at the end of today's event, you'll be able to make suggestions for other topics that we should cover on future educational webinars. This is a simplified graphic on how a claim gets into our system. The provider or the supplier renders the service, submits the claim to Medicare, but the system might reject the claim or claims. And when this occurs, we generate and send a 277 or 999 report. So this slide then describes that claim submission in a little bit more detail. Most providers submit claims electronically. Very few actually qualify for a waiver under a law that prohibits Medicare from making payment on a claim that is not submitted electronically. Now, to confirm claim receipt, providers should use the 999 report. Use the 277 report for more specific information. Our Electronic Data Interchange, or EDI staff, created the Medicare 276-277 Companion Guide. You'll notice that it is hyperlinked here on this slide. This is a guide that helps clarify and further define data content requirements for an electronic claim. Now, based on both reports, you'll know if the claim is rejected and if you need to correct or submit a claim. Here is a simplified graphic that shows what happens when a claim is deemed as unprocessable. Now that's a CMS term, unprocessable, and it means it's a rejected claim. The provider, of course, or supplier provides the service, submits the claim to Medicare. The claim gets into the claims processing system. However, because there is an incorrect format, something's not valid, something just doesn't make sense, that claim is rejected and a remittance advice is generated. Let's talk a little bit about the difference between a rejection and a denial. This slide shows a side-by-side comparison of claim rejections versus claim denials. Rejections, as I mentioned, are unprocessable. We talk about them in terms of they're really returned on the front end. They're returned because there's something missing or invalid or incorrect on the claim. Because they're never processed, rejected claims have no appeal rights. You need to fix it and resubmit it. When looking at the remittance advice for a rejected claim, you will see a MA130 and CO16 code on that remittance advice, and I'll delve deeper into those codes in just a little bit. But those two codes on a remittance advice is a clear notification for you or note to you that that claim is rejected. Because the claim's not processed, the patient is not liable. A denied claim, on the other hand, is actually adjudicated. It is processed. The service or claim is denied based on the fact that it fails to meet payment criteria. Now, this could be based on a law or what we call a statutory requirement. It could be denied because that service or services don't meet Medicare's medical necessity guidelines. This would include any utilization parameters or frequency guidelines, frequency edits. Sometimes claims are denied because of eligibility. Sometimes the patient is not eligible on that date of service, but sometimes it's also the provider that might not be eligible. On the remittance advice, you will see a MA01 code. On most claims that are denied, this does provide the appeal rights. You do have the right to an appeal for a denied service with very few exceptions, and I'm going to talk about one of those exceptions in just a little bit. For denied services, the patient liability is determined. So here then is the graphic that shows the path for a processed claim. The provider or supplier would provide the service, submit that claim to Medicare. The claim is entered into our system or enters into our system, and it doesn't meet payment criteria, so the service is denied, or it does meet payment criteria and we make payment on the claim, and that remittance advice is generated. I want to expand a little bit about the remittance advice. Talk about the importance of it. Sometimes we call this the remittance notice. Other times you might hear us call it the remit, shorten it up a bit, or even possibly the RA. Now, most providers receive an electronic remittance advice, or ERA, as opposed to a standard paper remittance, or SPR. The ERA will include details about the transfer of funds and payment processing from the payer to the healthcare provider's bank. Now, depending on how the claim is processed, it could include other information, such as any adjustments made to the claim. Of course, it would include information about denials. It could also include information about something that might be missing, and sometimes it provides notice about refunds and offsets. Codes on the remittance advice provide information about the claim, and I mentioned a couple of these to you earlier when I showed you that side-by-side comparison of a rejected claim to a denied claim. Claim adjustment reason codes explain why a claim paid differently than billed. And remittance advice remark codes provide more details about an adjustment that is described by the claim adjustment reason code. Another type of code that appears on the RA, or the remit advice, is a group code. I talked about one of those earlier, the CO16. Those are group codes, that alphanumeric code. These convey the financial responsibility for the unpaid portion of the claim balance. A CO stands for contractual obligation and means the provider is liable and can't bill the patient. If you see a PR group code on the remit, it means the patient is financially responsible. You can find code lists on the Washington Publishing Company's website. This is the contractor that maintains those codes for CMS. You can find the links, of course, in your handout here to those code lists, as well as the WPC's website. Now, we understand that some of those codes may be a bit cryptic. Some of them may be describing, or those reasons for rejections or denials could be a little out of date. And an example of that, and I'll point them out to you as I move on through this presentation today, are those code messages that include outdated information, such as an outdated acronym. And again, I'll point a couple of those out to you a little bit later on. I recognize that some of the acronyms that I'm talking about today are out of date. I'll describe them to you. I do recognize that those acronyms are no longer being used. However, because they are printing out in these rejection and denial reasons, I'm going to provide them to you just as they print out when we mine that data that I analyzed for today's webinar. Now, after reviewing your remittance advice, or the remit, you're going to need to choose the action that you need to take in order to fix the claim, correct the claim, resubmit the claim, or request an appeal. So for an unprocessable or rejected claim, you'll need to fix the error and resubmit the claim to Medicare. If the claim or claim line denied, there might actually be multiple actions to choose from. You might be able to simply resubmit the service. You might also be able to use the clerical error reopening or CER process, CER process, to correct those clerical errors. And CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. I'll talk more about the CER process later in this webinar. Another action to consider is an appeal, and the remittance advice, when there are appeal rights, will provide them. I'll discuss appeals also a bit later in this webinar. Now, registered users of our transactional portal can render a clerical error reopening or request an appeal using this self-service tool. And self-service tools are offered to providers, and we make those available because they really do offer the most efficiencies. Our portal user manual provides illustrations and step-by-step instructions on how to use these portal features, as well as many of the other functionalities that are available using the self-service portal. Here are just a couple of resources, CMS resources, in fact, that I'm sharing with you if you would like a little bit more information about the remittance advice. So next, I want to talk about when you need to correct or appeal the MAC's decision to pay or deny a claim. I talked earlier about the clerical error reopening, or CER process, and told you that I would share more details about it, and I'm doing so now. This is a process, the clerical error reopening, to correct those human or mechanical errors. And clerical errors or minor errors are limited to errors in form and content. They are not omissions, such as failing to bill for certain items or services. Now, your handout includes the link to a resource titled How to Request a Clerical Error Reopening. That particular resource available on our website includes some examples of acceptable clerical error submissions, such as mathematical or computational mistakes, inaccurate data entry, perhaps misapplication of a fee schedule or transposed procedure or diagnostic codes. There are also in that resource some examples of situations that cannot be processed as a clerical error reopening. Some of those examples would be a comprehensive error rate testing or CERT issue, provider enrollment issues, wrong payee situations, also some of those complex claim situations, those situations where perhaps you submitted a not otherwise classified or NOC code. Complex claim issues or situations would also be use of some of the modifiers, such as the 22 modifier, 53 modifier, 55 modifier, just to name a couple, or claims that require any analysis of documentation. Those, of course, would not be the types of situations for which a clerical error reopening can be performed. Now, you can use, as I mentioned, the portal for self-service, or you can request a clerical error reopening via telephone or fax. And remember that the portal user manual provides instructions. Here's that bit of information I said I would provide later in this presentation about appeals. Remember, when claims are rejected, typically, with few exceptions, they're going to provide you, or the remittance advice is going to provide you with a notice about your appeal rights. There are 5 levels of appeals. There are time limits for submitting and for completing an appeal for each of those 5 levels. There's also monetary thresholds for filing for a couple of the appeal levels, for appeals levels 3 and 5, as you can see there on this particular slide. For details about who can request an appeal, we have a terrific resource. It's actually on the next slide. I'm getting ahead of myself a little bit here. The resources that are available explain details about who can request an appeal. The beneficiary or their representative can request an appeal on any service process for them. Providers and suppliers, though, can appeal services for which they accepted assignment, with a couple of exceptions. For unassigned claims, providers and suppliers can act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement. Providers and suppliers can also request a redetermination, that's a level 1 appeal, on an unassigned claim if Medicare denied the service as not reasonable or necessary, or in those situations where the provider or supplier billed in excess of the limiting charge. And when that happens, in that case, the provider or supplier would need to refund any fees collected from the beneficiary over and above that limiting charge amount. And remember, we recommend using self-service options for more efficiencies. Here are the additional appeals resources. That first one is the one that I mentioned briefly when I got ahead of myself there. How to appeal a claim determination. This appears on our website, provides you with that information about who can request the appeal, where to send it, and so on and so forth. The other resource listed here on this particular slide is one of my favorite appeals resources, one that I go to very often because it's kind of a quick at a glance resource. This is the appeals process flowchart. It's the fee-for-service appeals process flowchart. CMS updates this annually, and if you look closely at the bottom of the graphic on the right hand of the slide, the last sentence there reads, "This chart reflects the amounts for calendar year 2024." Well, 2025 is coming up pretty quickly. So if you look at this resource or use this resource, this flow chart that I like so much, make sure that after the first of the year, you're making certain that CMS has updated this. Usually it takes them just a little bit of time to update this particular resource. But I like this particular resource because it explains both the standard and the expedited processes for appeals. The standard process is for parts A and B, and the expedited process applies for some Part A only appeals. I like this resource because you can easily see the 5 different levels of Medicare appeals. The first one, of course, is that redetermination that's done, the only level that's done at the MAC. Tells you that you have 120 days to file it. The MAC has 60 days to complete the review and their determination or their decision for the appeal request. So for each of the levels, you have days to file and the time limit for completing the appeal. I also like this because it does have those dollar amounts, those thresholds that I talked about early. For level 3, which is the Office of Medicare Hearings and Appeals, the AIC, which stands for Amount in Controversy, is equal to or greater than $180. And in federal district court, the amount in controversy is equal to or greater than $1,840. And these dollar amounts can change from year to year rather. Most often they do change, but sometimes there's been a few years where there was no change. So that's another thing you'll need to keep in mind as we move from calendar year 2024 to calendar year 2025. Great resource. I've really liked that one a lot. The next portion of this presentation then includes a discussion of the data that I use to provide the most common rejections and denials for specialty 19 oral surgery. Remember that as advertised today, this particular webinar focuses on that data that I analyzed, and I'll talk a little bit more about what I looked at in just a moment. But I want to remind you, if you're interested in learning more about policy or coverage or any other Medicare education that you can think of for oral surgery claims, something that I'm not covering and I didn't advertise that I would cover today, that survey that you're going to be offered at the end of today's event is a really great opportunity, not just to tell us how I did today, how Aline and I did, how we did, how you liked this presentation, but also to tell us what's on your wish list. What is it that you'd like to hear about in the future in our future WPS offered education events? So the data then that I am sharing today and focusing on is, as I mentioned, data for Part B claims, those submitted on the CMS 1500 or the 837P. These are specialty 19 claims for jurisdiction 5, which is Iowa, Kansas, Missouri, Nebraska, and that's for Part B. And for jurisdiction 8, Part B, which is Indiana and Michigan. So all 6 of these states collectively, we put all of the data into one bowl, as you will. Well, the dashboard does allow us to drill down by a specific state or states, and even down to counties. I pulled the data for our entire Part B claims jurisdiction. For those of you that are wondering what specialty 19 is, I've mentioned that a few times today. It is a 2-digit code that is assigned to WPS providers when they enrolled. CMS maintains that list of provider specialties, and during enrollment, providers self-designate a specialty. Now, while a provider can designate a secondary specialty and even a third specialty, it is only that designated primary specialty that is used during initial claim processing. There are some situations where a provider will request an appeal and they stipulate their secondary specialty, and then Medicare can consider making payment. But based on the editing and auditing within the claims processing system, it is only that primary specialty that's used during initial claim processing. So specialty code 19 is oral surgery. I pulled data for claim submission dates, April 1 of 2024 through June 30 of 2024. Now these are submission dates, not dates of service. So any claims submitted April 1 of 2024 through June 30 of 2024. The data that I pulled was last refreshed on July 12 of 2024 before I put this presentation together. So what this means is that if a claim was submitted for these dates, April through June, after July 12 of 2024, that data was not included in the data that I pulled and analyzed for this particular presentation. Here are the most common rejections by reason, and I'm going to touch upon these as I go through them, but I want to let you know or alert you to the fact that I have included the resources to avoid these rejections later on in this presentation. The first one is I kind of have to chuckle when I looked at it. You see, it starts out with the word denied. The third bulleted item and the fourth bulleted item also start with the word denied, and that's how the reason code prints out on the remit. However, these are rejections. That means they weren't denied, they're actually rejections. This is just one of those quirky things about these reason and remark codes that I talked about a little bit earlier. Some of them are cryptic, some of them include outdated acronyms. You could see one there in the fourth bullet. It says HCFA. We know that the HCFA 1500 is now the CMS 1500, but I just want to alert you to the fact these are common rejections. So the first one is that the CLIA number is invalid or missing. Well, what is CLIA? CLIA stands for the Clinical Laboratory Improvement Amendments. This is a federal program that establishes quality laboratory standards, and it's done so to protect patient safety and improve health care for laboratory testing that's performed. CMS oversees its regulation. CLIA generally requires that facilities that perform lab tests, including CLIA waived tests, to obtain a CLIA certificate. Then they must report that CLIA number from their certificate onto the claims. And when that information is entered incorrectly or isn't entered at all when it's required for a claim, the claim is rejected. This CLIA number is invalid or missing. The 222 that follows that particular reason for rejection is the number of claims in that 3-month period that were rejected, submitted claims. The next one is really kind of an informational only reason code that appears on almost many of the claims that are rejected. The claim lacks information needed for adjudication, 58 rejections. Typically when you see something like this, kind of a generic statement, you're going to look to other reason and remark codes on the claim form to really ascertain why the claim was rejected. The third most common rejection by reason for Specialty 19 is rendering physician number invalid, so it could have been entered wrong, or missing. Submit a new claim. So there you'll need to verify that the number was entered correctly, verify numbers match, the rendering provider to the billing provider. Check provider enrollment records. Make certain that your information is up to date and you're entering that information correctly on the claim. Next, rejection, not denial, even though it says denied. Field 11 of HCFA 1500 must be completed, 32 rejections. Item number 11 on the CMS claim form is where the provider tells Medicare if there is another insurance that is primary to Medicare. If there is none, you can't leave that field blank or that item blank. You need to place the word none into that item. I do want to show you a claims crosswalk because this will be a very helpful tool when you are preparing claims to Medicare. I'll make this a little bit bigger here. If you're on the and I've included, links to all of these resources, some of which I'm going to show you in today's presentation. So for those types of situations where you're missing something from the claim or there's something missing from the claim, if you go to the homepage of our website, under the quick links, you'll find EDI, which is Electronic Data Interchange. Scroll down the page. We're going to choose Medicare EDI. And on this page is the companion guides that our EDI staff has put together. Here's those companion guides. I talked about that 999 report, the 276, 277 reports. There's a companion guide for 276, 277. So this will help you make certain everything is on the claim that you needed. But what I want to show you right now is this crosswalk, the CMS 1500 to the ANSI 837 5010 crosswalk. This is a crosswalk that crosswalks the paper claim form to the electronic version. So for example, in column 1 is the item number. That corresponds to the item number on the claim. So item number on the claim is the narrative type of insurance, type of health insurance. This tells you the version 5010, these fields and loops that you place this information into in the electronic version claim, that 5010 claim. You'll notice this column here that says status. There's some R's there that show and some S's. And R means that it is a data element that is required to process a claim. So if any of these items where there's an R in the status column is missing, your claim is unprocessable. It's a data element required to process the claim. We can't process it because it's missing, okay, or invalid. Pay attention to this code. An S is a data element that must be completed, but only if other conditions exist. So that is a situational bit of information to enter on the claim. So you can see all of these item numbers here. This just crosswalks you from the paper claim form, and we were talking about item 11, the information you need. Here's this item 11C, the plan name or program name. Here is where you will need to refer to know what information you need to place on that claim. So for this example, field 11 of the HIPAA 1500, that's the CMS 1500 now, must be complete. If there is no other insurance primary to Medicare, you need to enter none. Denied, our service denied, again, there's that denied word, even though we're talking about rejections. Information required to make payment is missing. For this one, you're going to want to look at some of the other reason or remark codes to figure out what is missing from the claim. Here we have missing, incomplete, invalid ordering primary identifier. You have to place or identify an ordering provider on the claim when you are billing for certain services. CMS has a data set out on their website, and I've included that resource for you in the list of resources that comes later in this presentation that identifies all providers and suppliers that are eligible to order or refer, and it also includes their ordering primary identifier. Make certain that you're entering that identifier correctly. If you transpose a number, it's going to reject. Next up is invalid or missing modifier. On the WPS website, we have many. Let me see here. I'm trying to get it come up here. We have go back here to a WPS web page. That's CMS. Here's WPS. We have modifier fact sheets available on our website. You might be a searcher, you might be a navigator, but I like to use the quick links when they're available. So if I'm looking for modifiers, I would choose modifiers out under quick links. I would choose the jurisdiction that would be applicable. I'm just going to choose J8 MAC Part B. This is a Part B webinar today. Accept the licensure agreement. And here on our modifiers webpage are several modifier fact sheets listed. This will help you recognize for most of these, the appropriate use of a modifier, inappropriate use of modifier. Sometimes these modifier fact sheets have a bit of information that pertains to documentation or even more information. Sometimes they actually provide you these fact sheets, that is, when I say they, with the applicable codes. You know, you can use this modifier only for these codes. Here is a link to the CMS manual instruction that explains use of this modifier. So I just happen to choose modifier 22. There are modifier fact sheets for many of the fact sheets that we have available. And I got to come back to the PowerPoint here. All right, let's get back on track here. Claim must be submitted to RRB. RRB still stands for Railroad Retirement Board. A portion of Railroad Retirement Tier 1 and Social Security payroll taxes are paid by employees and employers that finance Medicare. It's also financed in part by monthly premiums that are paid by enrollees. So for these beneficiaries, those railroad retired beneficiaries, Medicare claims are processed by Railroad Medicare. The Railroad Medicare contractor is Palmetto GBA. So if a claim comes to WPS, it's rejected when that beneficiary is a Railroad Retirement beneficiary. The claim must be submitted to the Railroad Retirement Board. Next, invalid, incorrect ICD-9 code. There again, folks, is an outdated acronym. This should be ICD-10 these days. resubmit a new claim. So you need to fix that ICD-10 code and resubmit the claim. And lastly, facility lab name and address or PIN is missing. Again, this would be a situation where you'd want to look at the claim form instructions and make certain that you are entering into the item or the electronic equivalent all of the information that you need. So for example, if you're billing for a lab service, you need to enter the name and address for that lab onto your claim or the PIN. Here are, I thought it, in addition to just giving you the reasons for claim denials and rejections, to provide you with the codes that are rejecting. The top or the most commonly rejected code for your specialty, specialty 19, if you are an oral surgery provider, is this pathology code 88305. The top reason this is rejected is that it's missing or an incomplete or invalid ordering primary identifier, was on the claim or was missing from the claim. So what do you need to do? Fix it and resubmit it. Make certain it was keyed correctly. Make certain it's complete. You have all the digits necessary. Make certain it's there if needed. Other reasons for rejection of that code: claim has been forwarded to the Railroad to Retirement Board, or facility name and address was missing or not entered. You will see a couple of E&M codes here. One is the 99213. This is rejected because it's missing incomplete invalid billing provider primary identifier. So the billing provider was not correctly identified on the claim. Claims were also submitted or rejected because of railroad retirement. Should have went to Palmetto. And because the patient or the insured's Medicare beneficiary identifier and name do not match. You need to, on your claim form, match exactly what is on that beneficiary's Medicare card. If the middle initial is on the beneficiary's Medicare card, it needs to be on your claim. The next code, 41899, this is an NOC code for a surgical procedure. The clinic number was missing or not entered. That's why that claim is rejecting. Missing information needed to adjudicate the claim, and field 11 of the claim must be completed. Another surgery, 40808, same thing. Missing information needed to adjudicate the claim. Field 11 of the claim must be completed. And for this code, some claims were submitted where there were no charges submitted, so it was left blank. Next is the 70355. Again, top reason for rejection is missing, incomplete, or invalid ordering primary identifier. You need to enter that ordering primary identifier on your claim. It needs to be correct. It can't be transposed. It needs to be there. Perhaps it wasn't there at all. The 99202 is a new patient E&M code. The top reason for rejection is that only one E&M code for service level is covered per course of care. So in this case, there was more than one E&M code for this service level. So more than one new patient code entered. And Medicare can't pay more than one. So it was rejected. Patient MBI and name do not match. Again, check the card. And again, Railroad Retirement Board. You can see anesthesia listed there. Missing information adjudicated or needed to adjudicate the claim was the top rejection there. 40812. For this particular code, there was 10 rejections, invalid or missing modifier, and exact dates and charges needed. So it appears to me that because this 40808 and 40812 both rejected because exact dates and charges were needed, that perhaps some claims were submitted to Medicare where the dollar amount was not entered. And that last code, 76100, this is special X-ray equipment, allows viewing of only one body plane. That was rejected because the claim must be submitted to the Railroad Retirement Board. So fix it, resubmit it, but if it's a Railroad Retirement beneficiary, you would need to submit it to Palmetto, not to WPS. All right, we talked about rejections. I told you that I would also reveal the most common reasons for denial. The number one reason for claim denials for oral surgery is that the referring provider is not eligible to refer the service. So when you have those types of situation, you need to make certain if you entered a referring provider number that it was entered correctly. Perhaps that provider was not eligible to refer the service. And remember, I mentioned to you earlier that CMS has a data set published out on their website that has a list of all referring and ordering providers and their primary identifier. So that one you would need to check to see if that provider number was entered correctly, and if indeed that provider is eligible to refer that service. The next one is collection of fee for service during periods of managed care. This is a denial for those situations when a claim comes to the MAC. WPS is your Medicare Administrative Contractor, the MAC, when it should have gone to Medicare Part C because the patient has a Medicare Advantage beneficiary, and this would be an eligibility type denial. That patient has chosen a Medicare Advantage plan, so the claim has to go to the plan, not to the MAC. Medicare does not pay for this service by this provider. There were 76 denials there. The next one is a duplicate charge that was already paid on such and such a day on this particular claim. And those X's there really represent the first set, the question mark 002XX is really stands for a date, a month, day, year date. And the second that grouping of X's is actually an ICN that prints out on the remit. So it will tell you a duplicate charge was paid on such and such a day on such and such a claim. We get just an extraordinary amount of claims for duplicate services. If you within your office or organization bill like on a 30-day cycle, or if you employ a billing service that just automatically sends claims in if it's not paid within 30 days, stop doing that. It is considered abusive. Remember that there are payment floors. Medicare has to hold payment of a claim. So if it's in the processing system for the first, couple of weeks, and then we have to hold that payment for a certain period of time before we can send it out the door. Keep that in mind, the payment floor. Wait, don't just automatically submit claims back on a cycle if we haven't paid for them. Check the remits, do your due diligence. Check to see if you've received a remit for a particular item or service. Do what you can to avoid submitting those duplicate charges. They really cost everyone money, both the provider and Medicare. Medicare does consider repeated duplicate denials as an abuse. If you receive education and you continue to do it, it could even be considered fraud. So do what you can to avoid those duplicate charges. Not covered unless submitted via an electronic claim. 3,386. This one, it's likely, it needs to be submitted in an electronic claim. We likely got a load of paper claims into the system. We denied them because there was no exception to that rule or for that provider or those providers that would allow them to submit claims on paper. The Administrative Simplification Compliance Act requires all providers, with few exceptions, to submit electronic claims. When they're not submitted electronically and there's no exception, there's no waiver for that provider to submit on paper, they're denied. More denials, duplicate charge, 28 more. We talked about those already. The next one, the physician is not eligible to receive payments. This would be a situation where you'd want to check to make certain that the provider number is entered correctly, number one, or check provider enrollment records to see if the patient, or the provider rather, is eligible to receive payments. Medicare does not pay for this service in this facility. 23 denials. Check to make certain that the place of service was entered correctly, or if it indeed is a service that can be paid for when billed in that particular place of service. You can call customer service and ask, does Medicare allow me to bill this CPT code in this place of service? You have to keep it really generic though. You can't call them and say, well, the patient came into our clinic located at 123 ABC Street. You can't give all of those details. You have to keep it generic. Otherwise, we consider it a coding question, and CMS prohibits us from responding to coding questions. So ask, does Medicare or can Medicare consider payment for this CPT code in this place of service? If the answer is yes, then you know that the system accepts that code with that place of service. Doesn't necessarily mean it's payable, but it means that it will accept that place of service with that code. Procedure code submitted is non-covered Medicare service. If you look at CMS's relative value file, there is a status code assigned to CPT codes or HCPCS codes that will tell you if it is a covered Medicare service or if it's a non-covered Medicare service. Non-Medicare or non-covered services, those services that are covered, never ever payable by Medicare, do not need to be submitted to Medicare unless the beneficiary requests that you do so. Sometimes we recognize that you submit those services anyway because a supplemental insurer would need that payment denial from Medicare. But if you don't need to, you don't have to submit those non-covered services. Not covered when performed, referred, or ordered by this provider. This would be a situation where you would check out that data set that I talked about that has ordering, referring providers and their identification codes, or this could be one of those situations where the number was actually entered incorrectly. Let's take a look at those codes for common denials. 88305 is a pathology code. The number one reason why we denied this service: duplicate. Again, we want to decrease the number of duplicate denials. Those claims submitted to Medicare that are duplicates, so don't submit them if, unless, you've done your due diligence to see that it's not a duplicate service. Other reasons why Medicare denied this: Medicare does not pay doctors for tests done by independent labs for this particular service. Not covered when performed or referred or ordered by this provider, and provider number not valid for these services. E&M code 99213, this is a situation of denials because the pre and post-op care is included in surgery. We have a lot of great resources on our YouTube page that talks about global surgery billing. Typically, for surgical services that have a pre and post-operative period and intraoperative period, all of your E&M services will be in reimbursement for those services will be included in the surgery fee. Depends, though, on the number of global surgery days you have associated with that. But check out those great resources on our YouTube channel, and you will find some great education about pre and post-op care or global surgery. 99202, number one reason for denial: duplicate. Another reason for denial is that the patient has managed care or Medicare Advantage, not traditional Medicare that we process, and not covered when performed, referred, or ordered by this provider. 99203, managed care. Don't submit the claim to WPS. Time limit for filing expired. There is a great resource on our website that speaks to timely filing. I will show you it very quickly here. I just searched for I searched timely in the search box. Timely filing of claims is a great resource that we talk to the fact that you can only collect 20% of what we would have paid had we paid the claim. You have 1 year from the service date in order to submit your claim. One thing that I want to point out is this: we get a lot of questions for those situations when providers contact us and ask us to reopen a claim that's denied for timely filing when another insurer recoups their previous payment. CMS, in their internet-only manual, and the link is there to the CMS publication that addresses this. CMS says that third-party payer errors in making a primary payment determination does not constitute good cause for reopening an initial determination or redetermination when we have followed the timely filing rules. So that, folks, is where it says just because that other insurance comes back and takes your money back doesn't mean Medicare is going to pay. There are some reasons when, or legitimate reasons, I should say, when Medicare can extend that timely filing limit, but you need to submit or file a waiver. And this part of that article actually tells you how to go about doing that. Remember, you can see up here in dark blue, I'm on the J8 MAC Part B website. So we have on this page Indiana and Michigan addresses. If you are a J5 provider, you would simply go to the J5 jurisdiction and it would provide you with that same information pertaining to the states in J5. All right. Few other things here. 21030, physician not eligible to receive payment. So in other words, an oral surgery can't receive payment for that service, or there's something in the enrollment file that doesn't allow us to make payment for that provider. Another reason we're denying this is due to the fact that the beneficiary is a Medicare Advantage beneficiary, not traditional Medicare. For the 99213, dupes time limit, 99202, same thing. Duplicates, managed care, not covered when performed, ordered by this provider. So most of these denials are, again, all the same reasons. They're duplicates. The claim should have went to, Medicare Advantage. This service isn't covered when performed, referred, or ordered by this provider. Look to that data set that I provided for you to know if a provider is eligible to receive payment or order or refer services. Excuse me. 21030 is a code here that I just want to put. It's excision of a benign tumor from maxilla or zygoma. Medicare does not pay for this service by this provider. So what this means is that Medicare will not pay an oral surgeon to render that service for a Medicare beneficiary. So the service is denied. That's it for the denials. They were kind of all the same reasons that these were denied. Remember that we can do further breakdown of data. We can actually drill down to as far as to a county if we'd like, or for one particular provider. We can actually look at trending, and I provided one example here. This code description is that we denied a service because the units of service are exceeded. This has to do with those medically unlikely edits. Excuse me just a moment. So just to show you an example of the kind of data we can look at the claim count for the current 3 months period, which was for this denial, 10. We can look at the 3 months prior, 6. The difference in the number of claims is 4. That percentage of change is 67%. In the report that we look at, actually it provides a good visual because it will show you an arrow up or an arrow down to show you the data trend. Are we going up? Are we going down? And this is important because it helps us do what CMS has asked us to do. CMS has asked us to analyze the data to find the top rejections and denials so we can provide education on them to avoid them in the future. Okay, it saves everyone money, the provider and Medicare. It's a win-win situation. So here then are those many resources and tools that I've included. I've talked about a lot of these today. Real quick, I'm going to go through these. We have the Claims Processing Manual, Chapter 26, which provides you with claim form instructions. What do you put in item 1? What do you put in item 2? And remember, the crosswalk is available to show you if it goes in item 19 on a paper claim form, where do you need to put it on the electronic claim form? So there's that crosswalk that I showed you earlier. Here is our resource for rejected claims, and we list these by remark codes. Remember I talked about those reason and remark codes earlier on. So if you get a remit, your claim is rejected, it shows you remark code. I'm just going to use XYZ. It's typically an alphanumeric number. You can look to this article at that remark code and see how to fix your claim and resubmit it. And that helps you avoid it in the future. Here are claim denials. This resource suggests what actions you can take to avoid those common reasons for denials. I showed you the top 10 rejections and denials, and over and over and over, it's the same reasons that we are rejecting or denying these claims for Specialty 19. So if you look at the claim denials resource, and again, the link is embedded, we have these listed by category. So they're Bundling denials. Here's what you need to do to avoid these, or this is what you need to do when you submit your appeal. This is what we're looking for in the documentation, so on and so forth. There's global surgery rules. Some of those denials that I talked about today were denying due to global surgery. So that resource will tell you what you need to do to avoid those denials. Payer contractor denials, provider number denials, entitlement denials, and so on and so forth. So by category, some great resources and how-tos. Of course, there's our website. I do want to show you on the homepage of the WPS website, if you're looking for policy related information, and we didn't delve into that today, if you want to know if a particular code is included in one of our policies, you can look at the LCD, which is local coverage determination. That's a local policy. Key in your code number. You could see that a few of mine are suggested here because I've already looked up these, and hit your search button to see if we have a particular local coverage determination that includes that particular code in the associated article, the local coverage article that goes along with the LCD. You can also look up NCDs here in this code lookup tool available on our website. Another one of those self-service tools. Live events webpage includes a listing of all of the upcoming events. Encore presentations is where we place those recordings of our webinars for about 90 days, but remember you can also find them in the YouTube channel. A lot of the rejections and denials I talked about today happen because the patient has chosen or elected a Medicare Advantage plan as opposed to traditional or original Medicare, for example, WPS. So if you're looking for information about Medicare Advantage plans and how to get the claims over to them or what kind of plans there are, you can look out on our YouTube channel. We have playlists that categorize services. We have an evaluation and management services playlist, which the last time I looked had 47 recordings in it. So you can look by category. Went too fast here. I talked about CLIA rejections today. Clinical lab and reference lab services coding guidelines. This is where you'll find the information about CLIA, how you go about getting that certificate, where do you need to put it on your claim. Here is billing and describing not otherwise classified codes, one of the codes that was either rejected or denied. I don't remember which one at this point. Was an NOC code, and this tells you what you need to put in item 19 of the claim if you're billing for a not otherwise classified code. And if you need to submit documentation, what needs to be in the documentation. I've included this. We want to partner with you because a lot of the groups that I'm talking to as I'm doing this these many webinars for rejections and denials of specific specialty claims is that some of you belong to partner organizations or societies. Sometimes you're looking for education. We can do webinars for you. We can do in-person education. If you want to partner with us, this is where you can find that information. Provider enrollment guides and resources. Many of the rejections and denials I talked about today are those where you need to verify the provider number is valid or that this provider can bill for these services, or that Medicare will cover these services. You might need to make certain that your billing provider is connected, the individual provider is connected to the clinic or group that's billing. So that's all provider enrollment. So I've included those guides and resources. That modifiers web page I showed you is included here in your resources. E&M services guide is available out on CMS's website. Medicare National Correct Coding Initiative edits. I talked about those medically unlikely edits when I talked about trending. And when you bill more than the MUE on any given day, those services in excess are going to deny. This talks about how you find the edits, how you know those published MUEs, and how to use those tools, and how you can actually submit documentation and appeal a decision when we reject services in excess of the MUE. Here's that data set for ordering and referring providers. It also includes those provider numbers. Here's the relative value file I talked about, where there's that status code that will show you whether service is covered or not covered. Medicare Advantage resources as well. More CMS resources help for checking eligibility. There's also a review contractor directory interactive map that will allow you to see who the rail or how to get claims to the Railroad Retirement Board or other types of Medicare contractors if you need to submit to them. I want to briefly mention we have the IVR. This is a self-service tool, 24 hours a day, 7 days a week. You can find claim status and details. Currently, you can find eligibility information too, but this next slide provides an announcement to you that we are providing on behalf of CMS. IVR eligibility functions are going to be removed by March 31 of 2025. Here are the resources or the sources you can use to get eligibility information for Medicare after April 1 of 2025. All of this or this change, the fact that the eligibility functions are going to be removed from that interactive voice response is based on a change request that CMS issued. This provides the link to it. One of those tools that you can use to check eligibility, claim status, claim details. You can get more information on why a claim denied, and you can link to information that will help you fix that denial or submit your appeal, is the portal, our transactional portal. If you're on the WPS website, we have that portal user manual. Right here is the link. It's on every single page, both at the top and at the bottom under educational opportunities. There's that portal user manual, provides for you the illustrations and step-by-step actions to take to use the functionalities of the WPS portal. At this time, I do want to thank you for participating today. Remember, our greatest compliment is when you recommend our education to others. This helps us reach the greater provider community. Now, on behalf of myself and Aline and our entire provider outreach and education team, I do want to thank you for your participation. I look forward to your survey comments, and I hope to have you join us for future events. You may now disconnect. Thanks, everyone. Have a great day.